Hello, good evening, everybody. Myself, Dr. Naveen Kumar Kushwa. I'm consultant surgical oncology at Rajiv Gandhi Cancer Institute, Nitibag in South Delhi. The topic on which I'll be talking today will be the surgical challenges and post-operative considerations in NSLC lung after neoadjuvant chemoimmunotherapy. First, the disclosures. There is no financial relationship or industry funding related to this presentation. Neither there is any other associated conflicts to declare. So the very first thing is the purpose of having this discussion is what are the objectives which we are looking for. First is what are the goals of neoadjuvant treatment from a surgeon's point of view? What are the challenges which we face while give me a minute, please. Sorry. So first is what are the challenges which we face from a surgeon's point of view, and the challenges which are associated, particularly in cases of borderline cases, in cases of repeat, whether there is a need for repeat pulmonary function test, whether there is a need for restaging the mediastinum or not, and what are the important take-home points. So the important thing to understand is that approximately 20 to 25% of the patients who receive a diagnosis of non-small cell lung cancer have resectable disease. However, when we resect these patients, 30 to 55% of them, despite undergoing a curative surgery, have recurrence and ultimately die of the disease. So to overcome this very fact that because of this recurrence and there's this distant relapse, there came this concept of neoadjuvant chemoimmunotherapy in cases of NSLC lung. And this was the landmark paper which was published in New England Journal of Medicine, Checkmate 816 trial, which suggested that neoadjuvant nivolumab plus chemotherapy in resectable lung cancer. This basically included 1B to 3A, and they have suggested that if neoadjuvant nivo plus chemo has been given, then the event-free survival is approximately 63% versus just with chemo it is 45%. Similarly, the number of patients who are achieving pathological complete response are also comparatively much higher, that is in the range of 24% as compared to 2%. And finally, when now after the overall survival data of this particular paper has also come, in which again there is a significant p-value for overall survival at 5 years with 65% for nivo plus chemo arm and 55% for chemotherapy alone. So definitely once this paper has come, so definitely neoadjuvant chemoimmuno has a role. Now comes the part. So whenever we give neoadjuvant chemoimmuno to a particular patient, the thinking behind it is because there is a distant failure or recurrence. So first we want to eliminate all the micrometastatic disease early, both distant as well as local, whichever is which is possible. Secondly, once we give this thing, then there is a response assessment based on the scans and the pathological response. This guides us how well a disease is responding to a particular treatment. Third is from a surgeon's point of view, that once we have given a neoadjuvant chemoimmunotherapy, then we need to have R0 resections. There has to be a downstaging of tumor and lymph nodes so that our surgery becomes much more comparatively easier. And at the same time, the diseases which were entailing a pneumonectomy initially can now be converted to a sleeve or a lobectomy. So if we discuss the major trials which have been which are conducted where neoadjuvant chemoimmunotherapy has been utilized, are these four trials. One is the Checkmate 816, as already discussed, for 1B to 3A stages in which nivo was given. There is Asian trial where durva was used, Keynote 671 pembro was used, and 770 where again nivo was used, but it was used in adjuvant settings along with that also. So these are the four major trials. Now, all these trials basically, if I say collectively, all have shown a benefit in terms of the event-free survival. Now, when I say event-free survival, the event are basically recurrences or the relapses. So both of these, all these trials have shown this particular benefit. Now, so that means that if we give neoadjuvant chemoimmuno, we are definitely getting the long-term benefit. But from a surgical point of view, if we have to see that how we can label it, whether it is surgical compatible is not, is by checking these points, that after giving neoadjuvant chemoimmuno, whether there is any cancellation of the surgery, or there is any delay in the surgical procedure, or the surgical technical challenges which we face, we can basically judge how beneficial neoadjuvant chemoimmuno is from that perspective also. And at the same time, what are the advantages of doing an adjuvant systemic therapy instead. So this was a paper which was given by Ugalde et al., in which they checked for all these factors post neoadjuvant chemoimmuno. Now, very first thing, number of cancellations of surgery which we generally notice. So based on all the trials which I've already told, the serious adverse events grade treatment, and it has been found out that because of the treatment, roughly 16 to 23% of the patients do not undergo any planned surgery, either because of adverse events or disease progression, or they become unfit for surgery. As shown in this table, you can clearly see the percentages where there was cancellation of surgery despite giving neoadjuvant chemoimmuno, and the causes, and it has been equally divided accordingly based on disease progression, adverse event, and other scenarios. So one must always keep in mind that though we get that kind of event-free survival or PCR advantage, there are still 16 to 23% of the patients who were initially resectable, but we gave them neoadjuvant chemoimmuno and they progressed, or they somehow could not achieve this particular surgical course at a later point. Now, delay in surgery. Delayed surgery is generally considered then when there is a more than 6 weeks of interval from the last chemoimmuno, and this is observed in roughly 10 to 15% of the patients. And again, the factors responsible for it could be the neoadjuvant toxicity itself, the adverse events, logistic, financial, the general condition of the patient, and some other reasons. Now, this has been found out that the time to surgery is a very important parameter for short and long term outcomes post neoadjuvant chemoimmunotherapy. So this was a trial which was published by Tappa et al., in which they basically for a resected, though this was done for a resected uh, clinical stage 1 to 2 3 NSCLC patient, they found out that the time to surgery post chemo, if you see it, so greater the surgery is delayed, more than 8 weeks, more than 12 weeks, as you can see in the hazard ratio, it is 1.19, 1.31. So more there is increased 5-year mortality, there is also an increased tendency of 1-year recurrence. So resection within 8 weeks of the diagnosis is the important health system quality metric. So one needs to understand that time since a person is diagnosed to till he is treated is very important. The same applies for that neoadjuvant chemoimmuno. So if we give treatment, but because of these treatment itself, there is a delay, then that delay can actually result in a poor outcome in terms of 5-year mortality and recurrence. Again, you can see from this graph also, this is taken from this particular trial by Tapper et al. As you can see, as the delay increases, the for the delayed surgery, the outcomes in terms of survival probability are comparatively much poorer. So the timing at which the procedure needs to be done is also holds a lot of importance. Now, third is the technical challenges which we face. Now, technical challenges which most important is completeness of resection, margins wise, type of resection, and conversion to open surgery. These are the ones factors which basically decide what is the surgical technical difficulty which we face. Now, you see in this paper by Ugalde et al. That the number of R0 resections are almost in the range of 90 to 95% almost, beat all the trials. So the very fact that it leads to reduction and an R0 resection can be performed is almost uniform throughout all these papers. But the thing is, the type of resection, it has been seen that this conversion, the incidence of pneumonectomy, which was previously prior to chemoimmunotherapy, which was comparatively higher, that incidence also reduces, and patient can be managed with a sleeve or a lobectomy also. And conversion to open, I'll just discuss with you. So in Checkmate 816 trial itself, it was found out that the minimal invasive surgery was performed in 30% of the patients, and conversion to surgery, open surgery, was done in 11% of the patients. But these were not associated any significant adverse events as compared on NSCLC stage basis. Now, so this very thing that there are, because of the neoadjuvant chemotherapy, once the chemoimmuno is given, because of the immune based reaction and the inflammatory reaction, the comparatively the fibrosis are much more, the adhesions are much more, and these lymph nodal fusions are there. So these, all these parameters basically make the surgery more difficult. So this is a paper by Brunelli et al. In which they tried to assess intraoperatively a model to predict the complexity of the surgery. So what they found out that after chemoimmunotherapy, 43%, based on the parameters which they selected, that they were much more complex than a standard lobectomy. And the factors majorly which were independent predictors were that there was an absence of radiological nodal response to the neoadjuvant treatment, presence of a pre-treatment N2 stage, and PDL1 more than 50%. All these factors can be explained as well. Higher the PDL1, higher will be the response, to more the adhesions, more the inflammatory response. N2 disease, if it was previously, so more the N2, more the lymph nodal based, immune based reactions, so more the fibrosis and adhesions. So all these make the procedure more complex, and the possibility of conversion from minimally invasive to open are much higher if these factors are present. So to check for this in a more objective manner, these Lee et al., Spacey et al., Zhang et al., these basically gave uh, different feature-based tables so that the surgical complexity can be decided. But still, you will be amazed to see that uh, Spacey et al., when they conducted the study, they found out that 73% underwent lung resection by a thoracotomy. Similarly, in study by Zhang et al., 28.2% of the patient underwent vent surgery, and 7.5% who underwent robotic needed conversion to open. So conversion to open is a common entity post neoadjuvant chemoimmunotherapy. Only thing is that we need to resect the disease with an oncological R0 resection while considering in mind the safety of the patient. Now, another important entity which is coming up are the borderline resectable cases, generally stage 3B patients where there is a T4N2 disease. T4, and these are like a borderline scenarios where generally surgery was not considered and patient were usually shifted towards the Pacific trial for definitive CTRT followed by durvalumab. But now this trial by Biagio, in which they gave this neoadjuvant chemoimmunotherapy for these borderline resectable and even unresectable stage 3. So you will be amazed to know that 84 patients out of 112, roughly 75%, underwent surgical resection, achieving a PCR rate of almost 29%, with a major pathological response of 42%. And all those patients where the PCR could be achieved had a significant better median OFS. And this outcome with respect to PCR has been seen in other previous trials as well. Now, for the potentially resectable cases, same as stage 3A, 3B, this is something I just want to discuss, that in this table, if you look at it, that despite you can see the pneumonectomy was done in 5.9% cases only, And surgical complications, the 30-day mortality was just 0% in these cases. And the complication rates were also comparatively lesser. So yes, that the neoadjuvant chemoimmuno can even help us in treating these patients from a surgical point of view as well. This table shows the number of patients who achieved a PCR. Roughly 41.2% of the patients achieve PCR following neoadjuvant chemoimmunotherapy. And the partial response and the stable disease, the number is in the major pathological response patients, the number is quite significant to consider neoadjuvant chemoimmuno as an option. And all these patients, when they were checked from a progression-free survival or an over survival basis, this gap between the graphs is a clear indicator that all those patients who were able to achieve a PCR or an MPR were able to perform better as far as PFS and OS is concerned. Now, once this is done, what is the advantages of doing an adjuvant therapy? So it has been found out that as Checkmate 816, there was no adjuvant plan, but in other trials where the adjuvant was given as like AG and Keynote 671, Checkmate 770, in all these trials, Checkmate 816 could achieve the same outcome as a perioperative trial. So adjuvant therapy generally makes sense in cases where a PCR could not be achieved. Then in order to prevent a disease relapse or progression, disease relapse, then in those cases, giving an adjuvant immunotherapy is generally advised. Now, presently, there are new trials being developed. This is a phase 2 trial which is getting completed in April 2026, where MDT bridge trial, in which they were being given neoadjuvant durva, and based on their response of how the patient proceeded, they either moved to surgery and adjuvant durva versus a chemotherapy, radiotherapy, and consolidation. The results of these will be subsequently declared. So again, the trials are also being developed in such a manner that we can inculcate the very outcomes of neoadjuvant chemoimmunotherapy in our day-to-day practices. And if based on how the patient responded, we can move the patient from either to the surgery arm or toward the chemoradiotherapy or consolidation, particularly for this stage 3 and stage 3, 3A, 3B scenarios. Now, so as we can see, it has a good effect, neoadjuvant chemoimmunotherapy. Now comes the time that when we plan the patient from a surgical point of view, so does PFT, repeating the PFT has a role while planning for surgical resection? So yes, as you can see in this table, of patients of 575 patients who received induction therapy. So the patients where the DLCO was initially normal, but later it was impaired, then these patients require further optimization. So this guidance, very guidance, comes from this particular paper. It shows that the normal to impaired DLCO status was associated with the increased risk of respiratory complications and in hospital complications. So this gives us more prognostic idea. So if the DLC of the patient is actually declining, we require a much more better optimization of the patient prior to taking him or her for surgery, and we can accordingly counsel the patient. Same has been supported in the ASCO lung cancer education guideline 2025 also. Now, another important thing is, does EBUS needs to be repeated? Now, these are the consensus guidelines from the IASLC for the neoadjuvant and adjuvant treatment for early stage resectable lung. So they suggest that CT of the chest is sufficient, and in case of any absence of any radiographic progression post neoadjuvant therapy, invasive mediastinal restaging is not required. Now, the very basis for this is they are suggesting that just because repeating won't bring out any change if there is no radiographic progression, because otherwise also you will be resecting those particular stations of the lymph nodes. So a staging should only be considered if a disease which was previously an N0, but after, despite EBUS, but there were nodes visible on imaging. But once, even if you do, and there is some new finding, or the disease has retained despite being a N0 and N bus, then you need to perform a EBUS for proper staging even post neoadjuvant chemoimmunotherapy. So the take home points are that neoadjuvant chemoimmunotherapy is here to stay. We need to attempt minimally invasive as much as possible, but conversion to open is a common scenario. So one must not be afraid to do it as long as we can achieve an R0 resection. At the same time, despite all the possible attempts to avoid a pneumonectomies are still being done in cases because of the hilar adhesions and the fibrosis which is associated with neoadjuvant chemoimmunotherapy. Along with that, should we restage the mediastinum with EBUS? Not necessary in all the scenarios, as I have told. PFTs are very important to further optimize the patient, and for the cases of borderline cases